Okay, let's start. So, welcome to this seminar arranged by FRAM, which is a multidisciplinary center here at the university, focusing on chemical risk assessment and design of policy instruments. We are a special welcome to Vic Adamowicz, who's a professor at the University of Alberta, and one of the leading scholars, I think, on environmental valuation. So we're very happy that you are here, and we'll discuss and present around willingness to pay for health risk reduction and implications for also valuation of hazardous substances. And also, I think, a special emphasis on the role of baseline risk for this type of valuation exercises. So you will present for around 30-40 minutes, and then there will be some room for discussion and questions. Before we start, I should also say that we are filming this presentation, so we can use it in further activities of FRAM and so on. So, welcome.
Thank you. And everything you say shows up on this little monitor. I can see the little things moving whenever you speak. It'll show in the back of your head and your computer screen. Now everybody's turned their computers off. So. Thanks. It's nice to be here. Always a pleasure to come back here. I was able to navigate and find my way over to the building this morning, which I think is successful. Daniel and Thomas were helping me decide what to talk about, and I must admit I was struggling between how much economics and how much broader policy discussion. I don't know if I've got the balance right. I fear there's probably too much economic-y stuff in here, but we'll see how that goes. And then talking with Daniel this morning, he reminded me that my colleague Shelby Gherking presented some of this work at the conference in Helsinki, which some of you may have been at, that was on hazardous chemicals and such. This has been a topic in Canada that's been of interest. How do we deal with these multiple pollutants, whether it's in air or water? How do we handle very low risk toxics, but very real kinds of toxic elements within an economic framework? And so that's what I'm going to try to talk about. And we'll see how it goes. And feel free to interrupt or stop, and I can negotiate my presentation as we go. So I'm going to start with this rather horrible looking messy slide. So some of you may have seen this. This is from a paper in Proceedings of the National Academy of Sciences, relationship between water quality, change, multiple ecosystem goods and services, and changes in values. And they have this web. You probably can't read all the things that are on there, but they have various things, temperature, they have toxics down here. One big catch-all, toxics, pesticides, bacteria, I guess gets thrown into one. But then you have this whole trace of things through the system, and then eventually it shows up into people. So what does this slide tell me? Well, first of all, there's lots of things going on. And so actually understanding the linkage between the science and the human behavior thing is important. Second one is no human could ever figure out how to do all this. There's just too much that's happening in this context. So one has to make choices. And I'm happy to send you the slides if I see you're busily taking the picture of the slides, but I'm happy to share these with you. And this is straight out of the PNAS article. There's just too many things going on in this context for anyone to actually try to do everything. That's also part of the issue. I think you're going to have to choose. I mean, there are all these values. As a valuation person, for me, it's choosing, well, what should I be actually working on? Where are the big ones that I might be able to do? And the one that, I don't know if anybody's really tackled it very well, maybe conceptually we've tackled it very well, is that we tend to measure these one at a time when we do measure them. So value of fishing, how that's affected by toxics, or value associated with commercial production of fish, and then value of illness and avoided death. But then we just add them all together. I mean, literally, at least in the Canadian frameworks of how we use these modeling, how we use these modeling systems, we just take the stuff and put it all together. And that's not really the way to do it either. They're not perfectly additive. One has to think about the substitutions and how all they fit together in different ways. So even though it's an interesting paper and an interesting slide, to me it already says there are many things that we need to start thinking about unpacking how we move from the chemical side of things all the way to the human side of things, and then thinking about what we're going to focus on and then how we're going to add these pieces together. So that's just a kind of an overview. Where is most of my recent work on this and my colleagues' work on this? We're focusing on mortality and morbidity, human mortality and morbidity. So yes, I've worked lots on fishing, and if anybody knows, I've done way too many papers on moose hunting. I have a colleague who teases me about moose hunting papers. But really, if you look at most of the studies, the biggest values tend to be the work associated with mortality, sometimes morbidity cases, illness, whether they're in the air quality sense or the water quality sense. We're typically trying to understand marginal willingness to pay to reduce risks. So we frame it in a risk context, trying to understand multiple endpoints at times. So there may be multiple illnesses that we have to think about multiple risks from. Thinking about it in a context. Is this something in the water? Is it something in the air? Is it something in industrial products? Where is it coming from? So that we get a little bit better sense of both the pathways, but also how people value depends on the context of these issues. Are we thinking about dealing with it as a public good, or are we thinking about it as some kind of a private good that people can buy something to offset the risk, or that they can buy a different product? And then are we using revealed preference or stated preference? I must admit, much of the work I'm doing on this is in the revealed or in the stated preference world, but we've also done avoidance costs and averting behavior and those types of things in the revealed preference world. So that's sort of where I'm headed, thinking about it as the health risk side of things. I wanted to pull up, this is actually a slide I pulled out of an old paper. We did some work about, started actually about 10 years ago, and Health Canada came to us and said they were struggling with dealing with water treatment, and the fact that depending on the water treatment they chose, they would get disinfectant byproduct problems, they would get trihalomethane concerns, and they were really wrestling with the mix of different contaminants. Should we use chlorine treatment to reduce microbial illnesses, but chlorine treatment has its own byproduct side effect questions and a whole host of things around that. So we wrestled with these types of trade-offs. We designed an instrument, and so we've done a bunch of this work. And again, it's thinking about what are actually the risk issues, how do those translate into endpoints, mortality risk, morbidity risk, and how does it churn out values that we use in different contexts. And that's sort of old work, and I'd be happy to talk about what we learned in the policy context from that. The lessons learned were quite interesting. It was basically keep doing what you're doing. It was one of those cases where, we always look for policy change from the work that we've done. Sometimes the advice is you're doing fine, don't change anything. That doesn't show up very well. It's very hard to measure that kind of policy outcome. So it's just one to put into the background. All right, let me focus a bit more. We could stop right at this slide and not talk anymore if we got into a discussion about all the issues that I think we worry about. But I'm going to pick off a couple of these and get into a case study of them. What are the endpoints? To me, is the first one. What is it actually that is affecting people directly from whatever it is that's changing in the environment? What enters their utility function in the economic speak? Daniel mentioned this notion of baseline risk. What is the baseline risk? And what is the change? It's either changing because of a change in the environment, because of pollution issues, or it's changing because we're implementing some policy that reduces those risks. And then what is baseline risk? Is baseline risk something that we measure objectively by putting a probe somewhere and figuring out what some human health risk is? Or is it what actually individuals feel their baseline risk is? Because individuals can, to a certain extent, change the risk that they face from an external environment. And that's the case that I'll be talking about. If there are risks associated with illness because of air quality or water quality, there are various things that I can do to protect myself. I know that. I know what I think I'm doing in terms of my changes in risk. Some external measurement doesn't capture that. And so I'm going to spend a bunch of time talking about perceptions and risk perceptions and how people interpret risks from the environment or interpret risks to health, and whether we can think about that as baseline risk. I'm also likely going to get myself into huge trouble because I'm going to say some specific things about what we see in populations that we're doing research on but I'll wait until I get to that piece. Endogeneity, this ability to self-protect, is going to influence value. It's going to influence how we interpret those value measures. If we're thinking about saying, yes, this is a really important change, it has a large impact, we're going to think about that one. Heterogeneity, this is actually something that's I've been quite interested in lately. There's a lot of discussion in my world about heterogeneity and preferences, that people have different risk preferences or different preferences for goods or services. That may be very much confounded with the fact that they have different perceptions of what the characteristic of the product or good is. There's some really nice old literature by Mansky and others that says we have this fundamental identification problem in economics. We mix up perceptions and preferences. And I think that's actually quite correct. We claim that people have different preferences. Well, they may just have very different perceptions about what's going on in the environment or with that product. Their preferences are all the same. And that matters. That matters because preferences change. Perceptions change. Perceptions can be influenced by information. So a lot of that will really temper what we say about values and benefit cost analysis. What's the risk context? What's the health endpoint? What's the pathway? How are we measuring things? And often we're talking about very small risks. And that's tough for people to process. We know that people have systematic processing biases or inaccuracies at times, if you wish, depending on these cases. We know that there are information acquisition issues with very small risks, so we have to struggle with how do we deal with these processing challenges within the context of valuation. And then the last one is, actually, Frederick, you helped us with this one with a thesis defense several years ago. Altruism. If I'm thinking about my value for improving water quality, for reducing the health risks associated with something in the water, is it for me or is it because I want to protect everybody? I want to protect my children and I want to protect people when they're at the grocery store and I want to protect my grandparents. In benefit cost analysis, that gets tricky as to how we actually deal with altruism, how we measure it, how we incorporate it into analysis. I think it's definitely there. The difficulty is sorting out what the source of that altruism is, and that we have trouble with, trying to figure out how to do. Okay, should I stop there now and we'll just have a discussion on all of these, or do you want me to keep going?
Keep going.
Okay, good. Daniel says keep going. This gives me a chance to get myself into trouble. Okay, I'm going to pick one example. Has nothing to do with water, has nothing to do with hazardous chemicals, but I think it illustrates some of the points. It's work that we've actually been wrestling with for years with various papers. It's on health risk valuation, focuses on the issue of baseline risks. We've got a pretty standard economic model that we use, but that model is a function of baseline risks. So we have to think a little more carefully about what baseline risks actually are. The context in this one is actually air pollution. The policy context was air pollution. The policy context is around what are the benefits of improving air quality, reducing particulate matter is the specific focus. And the endpoint focus in this is heart disease. But you can think about this generically as it's some kind of environmental risk. There's some health endpoint. We're trying to understand people's preferences so that we can understand the value of improving the environment. And that's the broad general context. What is the baseline risk? I already mentioned that. Is baseline risk something objective that we just pull out of the monitors, or is it something that people have their own information on? And again, our notion is that in this context, air quality, heart disease, that people can affect those risks. They can change their own risks of heart disease in various ways. Is it perceived risk? Are those accurate? I put accurate in quotes. I like to use quotes when I don't know what I'm saying. I don't know what accurate actually means in this context, because we have good snapshot measures of what objective risks are, or the chances of a person getting heart disease over some period of time. Somebody might perceive that their risk is different than that. That could be perfectly accurate in their personal context. It also could be perfectly accurate in the sense of going forward, how those risks may change over time with health technologies and other things. So lots of fuzzy pieces in here. Is risk exogenous? Probably not. Is marginal willingness to pay increasing or decreasing in baseline risk? Now that seems pretty narrow. I'm going to try to convince you that that's actually a fairly important thing. And I'll describe the policy issue as to why I think that's important. The answer to that question is, in the theoretical world, we don't know. It could go either way. And so we've got to think a little bit about the empirical side of things, and we think, at least for our data, we have an answer of which direction that goes, and it's not the standard answer. Are we observing heterogeneity when we see different risk values, heterogeneity in preferences, or is it differences in perceptions? That's back to that story that there might be a fundamental confound between preferences and perceptions, and at least in what we're seeing for our specific form, it actually looks like perceptions. It looks like people have very similar preferences for risk reductions, but because their perceptions of their own health risk differs widely, we see very different values coming out of those. What are the policy implications? We'll get to that at the end if there are any of those. Okay, good to go? So this is a story of why I think baseline risks matter. And probably if this is these next 2 or 3 slides are the only things you take away from this, that's okay. The rest of it is just detail. So this is the old US benefit cost analysis on the Clean Air Act amendments. So this is basically said, what's the benefit associated with improving air quality, given the Clean Air Act amendments? And the total benefits are this massive number, trillions of dollars. The total costs are this tiny number. This is also probably the most detailed benefit cost analysis I've ever seen. But a huge difference in benefits versus costs. The vast majority of that benefit is from reduced mortality. There's a whole list of different things in that. There's reduced morbidity case, there's impacts on agriculture, there's impacts on scenery, there's a whole other list of benefits associated with improving air quality. The vast majority of it is mortality, which is interesting in itself. And that kind of goes back to an earlier point I made. What of course keeps some of us awake at night is, what if we have that benefit measure wrong? Or if we're not valuing that mortality side correctly, then the biggest estimate in there is a bit shaky. I'm not saying we do, but it's a concerning issue, just given the emphasis on mortality. So this is a funny looking graph, but this is baseline mortality risk. Deaths per 100,000 people on this axis. What we do in the policy world when we calculate the benefits of risk reduction is we calculate how many fewer people are going to die because we've got cleaner air, and then we basically multiply that by a number. And that number is the single monetary measure of the value of mortality risk reduction. Okay, that's fine if the context that we measured that number at is essentially the same context as the real world application that we're using, because then the numbers should match. That would mean that marginal willingness to pay is essentially constant over baseline risk. If these are all the different baseline risks, there's some context where there's very small risk, there's some context where there's a larger baseline risk. This is what we do in the policy world, the red line. If the marginal willingness to pay changes with baseline risk, if it changes the way this green line changes, we use this measurement up here for policy, but the real world is down here. We've goofed by a lot, by this massive amount, on the measurement of the value of the risk reduction. In other words, at these very low risk levels, the marginal willingness to pay may be very high if the baseline risk takes this relationship. Whereas at the real world risk, it's a much lower marginal willingness to pay. If we get that number wrong, then we've got the policy context quite wrong. Seems pretty straightforward, but we haven't had a lot of work done on actually empirically measuring how marginal willingness to pay changes in these different baseline risk contexts. Surrender.
You've taken the most extreme.
This is the most extreme example possible, right? Most extreme example possible. It's not completely fictional. Not completely. This isn't where I'm getting myself in trouble, by the way. I'm less trouble over this than what's coming. But if you look at the numbers, at least one set of numbers that are often used for the value of mortality risk reduction, it's numbers from workplace mortality. Workplace mortalities are actually very low risks, especially in the US context or in the Canadian context. So that's where some of these numbers come from. They come from very low baseline risks, and the valuation is being calculated there. But if you go to what the baseline risk is in the world for particulate matter, you're more likely out here. Now, we don't actually know the shape of this curve. Maybe it slopes this way. Maybe it's not quite so extreme. But if the curve looks like this rectangular hyperbola, then we're getting quite a large difference in these outcomes.
We can't see the axis. What have we got in there?
So this is annual marginal willingness to pay, and this is baseline mortality rate, deaths per 100,000. So the deaths per 100,000 in the workplace are tiny, like 2, 3 per 100,000. The deaths per 100,000 estimated from the change in particulate matter is more in the hundreds per 100,000. So quite a difference in the baseline risk changes.
And our willingness to pay to reduce these workplace risks is really high.
Yeah, that's, if in fact that part is true, it's a question of whether it's constant or whether it actually declines. Or it could increase. I mean, that's the other one. I drew the graph with a declining marginal willingness to pay. As I say, but in the theory, we don't actually know which direction it goes. We have some guesses, but we don't actually know.
Is it a matter of whose responsibility it is? I mean, in the workplace, there's a company who employs you and you can sue them, and so that sort of drives up values, perhaps.
That's not part of the theory, but I could see how the context might change the direction of this. Yeah.
So follow up, because you're really saying this is the difference in baseline risk. So I can think of many other factors.
Oh, absolutely.
So comparing,
Absolutely.
say, airline, going by
Yep.
air, going by car, different baseline risk, but there are many other reasons.
Yep.
But you're saying here that
Yeah,
you're going to
I'm
keep
gonna
that
abstract
constant.
from that.
Okay.
Yeah, that's another. That was another one on my shopping list of
Okay.
things that will keep us busy forever. If we solve all these problems, then we're out of work. So it's good to keep thinking about problems. Okay. Now, one of the ways that we've approached this is this issue of baseline risk and the relationship between baseline risk and willingness to pay is to think about endogenous versus exogenous risks. So there is some literature, exogenous, if the risk is exogenous, in other words, I can't change it, it's something that's basically externally imposed on me from the system, willingness to pay increases with baseline risk. So that's the opposite of what I showed before. There's some evidence on the endogenous side that it may decrease with baseline risk. Now, I think, at least for the risks that I'm focusing on, heart disease risks, those are probably endogenous risks. I mean, people can do things to change their risk of heart disease, irrespective of what's going on in the air quality or the natural environment. What we've seen in the empirical world is various estimates all over the map. I'll keep track of time, but I'll do this fairly quickly. This is the standard model, right? The standard model just says, the simplest standard model says, you've got a chance of being healthy or you've got a chance of dying. There's some risk of dying in a generic sense, so abstracting from all the different sources of risk. We know what the marginal willingness to pay is. Under reasonable assumptions, the marginal willingness to pay is positive. Not always. That's also an interesting feature. And if we make another set of assumptions, then it's true that for exogenous risks, marginal willingness to pay is going to be increasing in baseline risk. That's the so-called dead anyway effect. So if I'm going to die anyway, I might as well throw all my money at reducing the risk because I'm getting no utility from having that money kicking around when I'm dead. This is a morbid topic. It's a wonderful thing to chat about. But that's basically the explanation. But it still is under a set of assumptions. If we change the world to be endogenous, then all of a sudden now we can spend money on something X. We can spend money on exercise or air conditioners or other types of things and actually reduce our baseline risks. And there's a question of how that interacts with a government program to reduce air quality or to reduce risks in some other way. And so the productivity of those two things interacting is really what's going to be affecting whether marginal willingness to pay increases or decreases in baseline risk. So this really is a case, well, Liu and Nelson actually claim that it does go the diminishing way, the way we've done it, at least in the circumstances that they talk about. In the empirical world, I'm not sure. And certainly It actually makes more sense in the mortality case than it does in the morbidity case because of the assumptions, and we can talk about the gory details in that. You can do the same things if you do morbidity. Again, I'm not going to spend time on this, but in our particular application, we actually assess risks to parents and children, so parents and their children, and so we have a more sophisticated model with kids and adults floating around in it, but you get the same basic outcomes. Okay, let me skip by that. So what do we want to do? We're going to try to measure marginal willingness to pay for heart disease. We're going to try to figure out how this interacts with baseline risks. We're actually going to elicit perceived risks. This is one of the craziest things one can ever do, but it's quite entertaining. We're going to measure that marginal willingness to pay for risk reduction, in this case using a stated preference estimate. We're going to see what direction it goes, recognizing that these baseline risks are endogenous. So these are things that people are telling us, so they will be influenced by various factors. And then I'm going to talk a little bit about heterogeneity in marginal willingness to pay. And without lots of econometric estimates or gory details, because we'll run out of time. But those are available if you really wish. Big survey, knowledge network survey, so not an opt-in survey panel, a relatively good random sample of individuals. We have a lot of folks that we put into different groups. There's over 3,000 people. Lots of pre-testing, focus groups, a whole host of other things. Because we were doing things with both parents and children, we were matching spouses in some cases. I'm going to be using different samples and different sets of numbers to describe some of the results today, but we have samples of matched spouses and unmatched spouses and a whole host of other things. We asked people about their own risks of heart disease. We asked people about their children's risk of heart disease. And that's for one child selected at random. Actually, I'm just dealing with review comments on this, and a reviewer's beating me up on why we did that and not ask about how many children. It's not one of you in the room, I hope, but it's an interesting one. And it was all done on computer, all done with panel members with a variety of controls. When the two spouses are answering, they're hopefully not answering one person for both of them, things like that. Without a lot of detail about all the other survey pieces, we used a host of different instruments to try to elicit risk and communicate risk. So what are the chances that you might have coronary artery disease before you reach age 75 will be a function of how old you are, your health status, and a whole host of other things, genetic issues and all the rest. So that's why we felt there is no single objective measure. Somebody couldn't just say, this is Vic's chance of getting heart disease. I have better knowledge about things like how much I exercise and whether I smoke or not and other kinds of things that should tell me more about what my baseline risk is. We teach people about probabilities, or try to. We test them. They hate that. Anybody who's done surveys knows that when you test people, they get annoyed with you. But we also keep track of those that aren't quite getting the probability side of things. Not a huge percentage, but there's always a percentage. And then we use this instrument to try to actually elicit their baseline risk. What are their chances of getting heart disease? We do it in two ways, and this is on the next slide, but since I'm here, I'll say it. We do a kind of cold assessment. Just what do you think your chances are of getting heart disease before you are 75? And then we provide them with information about, okay, general population's affected in the following way. If you're a smoker, you're more likely. If you exercise lots, you're less likely, et cetera, et cetera, et cetera. Do you want to change your estimate? And a whole bunch of folks change their estimate because they've gotten information and they think, oh yeah, okay. They almost all revise their estimate down, but not everybody after they get information. We provide them information about smoking, cholesterol, blood pressure, diabetes, body mass index, all those kind of things, the direction that will affect the chances of getting heart disease in trying to elicit perceptions of baseline risk. Okay, here's where I get myself in trouble. This is one of the sets of answers. So here are, I'm going to get myself in trouble. I'll put this on the table right now because this varies by gender. Now, 30-some years ago, Jack Kinech told me you can report the coefficient on a gender outcome, but don't try to explain it. So I'm going to stay in that camp. I think that's wise. So I'm going to report what we found. Men, initial estimate, 37 chances out of 100 of getting heart disease. The objective risk on average, this is the average. The objective risk on average Best information we have is about 35 chance out of 100. Pretty close. So the averages are matching what the American Medical Association and others tell us. Women have a lower chance of getting heart disease, 35, that's consistent in that sense at least. The objective information is 19. That's where you see I've gone silent and haven't said anything. That's a puzzle. It's not unique to our case, and I'll come back to that in a minute. But these are essentially their initial calls. You can see what the revised numbers are. People revise down. Everybody revises down somewhat, not a huge amount. So there's also a question of what is accurate. So remember that piece. This is what the snapshot, American Heart Association and other studies says the risk of getting heart disease for women is. But that could be changing as well. And people could be forecasting, looking forward as to what their actual estimates are. And that could be going different directions for different genders. The interesting part in there is that we actually do have some accurate, if you like, measures in this context. If you're a smoker, let's look at the objective probabilities versus people's perceptions. If you're not a smoker, your chance of getting heart disease are lower than if you are a smoker. Men or women, 5 to 7 points, depending on where you are. If you ask people and divide them up by those who are smokers versus non-smokers, they get it about right. So it's a little bit different, but they get it about right, at least in terms of the size of the change. So smokers know that their chances of getting heart disease are higher than non-smokers. Interesting information. That's what you would expect. We bombarded people with information about the risks of getting heart disease and risks associated with these kinds of interactions, and they seem to have that right. Raises interesting questions about how much one should spend on additional information around this. Folks are still making their choices. They're still calculating in theory, calculating their risks, and they've got it about right in terms of their perceived risks on average. When you go to body mass index, of course, there's an increase. At least I got the direction pretty close to right on the male side. The female side, direction is right, changes are pretty close, but the magnitude is higher. We go to people who have diabetes. No, yes is a massive increase. If you're a diabetic, your chances of getting heart disease are quite a bit higher. This is the objective information. People recognize that, but not as much. All right, this is 67 versus 47, so quite an underestimate. Same thing on the women's side. All right, what's the moral of the story before I really dig myself a deep hole in this context? It seems for this one that in certain cases we get fairly accurate, if you like, or consistent estimates of perceived risks on average to what the objective information would be. Individuals are different, and that's what we expect. They vary across the case. For some of these outcomes, we're seeing that we're getting an accurate representation of changes, whether you're a smoker or not, but for others, we're not. Yeah?
Are those objective probabilities and also the subjective ones? So, for example, smokers, are they measured at the average of all the other categories?
The average of the smokers.
So that's the average of the smokers, so all the other categories should be kind of averaged as well, or is
Correct.
it?
Yeah, correct. So let me go to the words part of this, is what I've already said. Some measures of marginal risk are very accurate, some are not. So maybe there's an occasion for information provision in the case of diabetics, for example, that in fact you're underestimating your chance of getting heart disease because you're only at the 40% level where the objective measure is 60. What's the role of information? And then this is the one where I get myself in trouble. Why do women appear to be pessimistic? There's actually several studies. I've picked out one. There's some really good work by Hurd on various ways of measuring survival probabilities and finding the same outcome. And there's a little quote in here. Men are slightly pessimistic, women are quite pessimistic about their mortality risks. And I've got all kinds of interesting ideas generated from folks about what's going on in here. I don't know what the answer is, but I think it's an interesting case. It does also raise this question that I've already mentioned. There's this whole literature that says that, or suggests, that women are more risk averse than men in these environmental preference contexts. Well, maybe they're not. Maybe they just have different risk perceptions. that their perceived chances of a health outcome are different than male perceived chances of a health outcome. And it's not a preference difference. And so that's a twist that we're not seeing in the literature. Remember, those two are confounded or interacting. We take these baseline risks, and then we, for every individual's baseline risk, we then offer them something that would reduce that baseline risk and see if they'd be willing to pay for that treatment. We present them with a vaccine, in quotes. Standard sort of stated preference application. I could talk about all the controls and the things we try to do to avoid hypothetical statements, et cetera. But we're getting what we would expect, that if you offer somebody something at a high price, they're more likely to say no. If you offer them something at a low price, they're more likely to say yes. We offer them that for both their own case and their children. We get this type of outcome. Marginal willingness to pay for a reduction in 1 percentage point in heart disease, about $2, $2.50 for parents, a little less for their children. Those turn out to not be statistically different, which is interesting. So, Brendan?
What do you mean by a vaccine for heart disease?
Yeah, so it's actually a health treatment. We call it a vaccine as our code word in the paper. But it's a health treatment that will reduce your chances of getting heart disease. It doesn't have side effects. It's a dietary thing that we describe in the survey.
Irrespective of which of those bins you are in. It
You're-
is the same.
It's not, that's correct. It's not tailored as this is your specific treatment. It's tailored as, it's described as this treatment will have the following outcome. So there could be people, it's a percentage reduction from their baseline risk.
So how much would you be paying to eliminate the risk for heart?
To eliminate it, if you'd have to make an assumption of the curvature in that.
But it's not simply multiplying this by 100 or by 20 or by
No,
something
that's
else.
correct. It'll change depending on the curvature.
So it's more, yeah, that makes it harder to
Exactly.
kind of know what this is.
Exactly. But if we take, this is for 1 percentage point. If we take that for 1 chance in 100, this is the way we presented it to them, right? The 1 chance in 100. And again, we're being extreme, but if we apply a rectangular hyperbola, which is just moving from percentages to a 1 chance in 100, then it depends on the baseline risk. Somebody with a baseline risk, a very low baseline risk, their willingness to pay is very high. Somebody with a very high baseline risk, their willingness to pay is very low. And so that's imposing a functional form assumption that is the same shape as that one I presented for the air quality risk. That's just telling the same story. So the question is this right? Is this type of a structure, rectangular hyperbola, or some other nonlinear or declining in baseline risk willingness to pay measure appropriate?
But this is an endogenous baseline risk now, right? So this is going to depend on who, so you will have men in one part of the baseline and women in another part, right?
Correct. They all have their own baseline risk. We randomize the percentage change, right? So that part is randomly assigned. So we have solid estimates of the percentage change in baseline risk because of the random assignment, right? The tricky bit is how can we then avoid endogeneities associated with the baseline perception of risk in the econometric estimates? We can chat about that.
Okay.
We try. It's not perfect.
I thought your goal was to try to get the shape.
We are.
Okay. Come.
So one of the ways of getting the shape is by starting with this rectangular hyperbola and then testing to see whether baseline risk affects that shape. And we've got a little proof in the paper about how the interactions between our randomly assigned variable and our baseline risk, which is endogenous, that asymptotically those will be consistent. So we enter that as an interaction as a covariate. Lots of technical details in here. If you're interested, we can talk about them later. We do tests also ignoring the fact that baseline risk is endogenous and just look at that. And all of our estimates suggest that, yes, the relationship between marginal willingness to pay and baseline risk is declining. And here's just a couple of the econometric estimates. This is our percentage risk reduction. That one's randomly assigned, so that should be perfectly fine as an estimate. Vaccine prices randomly assigned. Those are nice and significant. When we start interacting with the perceived risk, which is endogenous, we're getting not significant estimates. So we're not seeing any changes in our rectangular hyperbola estimate. And that's, to us, evidence that suggests that that thing has that declining nonlinear shape to it. We do the same thing by just putting absolute risk reduction in directly and then interacting the absolute risk and the perceived risk, we get a negative sign. So we get that thing declining as we go through in that space. So what does it suggest? Marginal willingness to pay declines with increases in risk. So it has that interesting shape. It's actually not as steep as that nasty example that I presented. That was an extreme case, but it does have that same kind of curvature, which suggests we've got to worry about where we estimate the risk versus where we apply it for policy. Supports the endogenous risk model. I mean, in some ways, that shouldn't be a big surprise. One would expect with heart disease that there would be endogeneity in the risk estimates. Broadly consistent with similar analysis of absolute risk reduction, percentage risk reduction comparisons. So that's two pieces of the puzzle. What about heterogeneity? Well, let me show this. This is, again, the same sort of graph. What this is saying, if we do have this relationship between marginal willingness to pay and chances of dying or getting sick, we get these interesting things that pop up. Higher income people actually seem to perceive lower incomes of heart, or lower chances of heart disease. Now that may be because they're spending money on exercise or spending money on better diets or other types of things, but the higher income associated with perception is actually driving the difference in marginal willingness to pay. So that's a different way to interpret baseline risks and demographic variables. People who are in better health perceive lower risks of heart disease, so they have higher marginal willingness to pay, which is not the way we usually think about these kinds of outcomes, but it just puts it in a different context. Just click. Last bit. How am I doing? Only a couple of minutes left. Heterogeneity in perception rather than preferences. So we take our model and we examine how people's preferences may vary by a variety of demographic factors. There's a huge long list of them. The preferences vary by whether you're a smoker, body mass index, whether you're diabetic, high blood pressure, et cetera, et cetera, et cetera. We find none of them are significant. The percentage change, the preferences associated with the percentage change in baseline risk reduction are not affected by these demographic outcomes. They are affected by perceptions because the perceptions, of course, vary across people. So if we take that same list, smokers versus non-smokers, you see a difference in their marginal willingness to pay. Diabetic versus not, you see a larger difference. So in our case, given this structure, the heterogeneity is perceptions, not demographic characteristics. And again, that's quite different than you would see in the literature. We would see that people of different demographic characteristics or backgrounds would have different preferences. And here we're saying it all comes down to how they perceive their risks. Possibly interactions, but it all comes down to how they perceive their risks. All right, let me back up. Yep.
Demographics might be driving perceptions. If you put them
Absolutely.
both in, the demographics are losing and perceptions are coming.
So demographics on their own aren't showing any differences in our marginal willingness to pay numbers. It's all coming from the perception side. So in a sense, what we're trying to do is untangle that confound between perceptions and preferences. We have to impose some structure to do it, so don't buy this story completely. Read the paper, see if you're convinced or not. But that's what we try to do, to try to untangle that confound. All right, I think I've said most of this. Let me get to my shopping list at the end. So, well, what's the policy implication? Well, we have to know baseline risk. And if baseline risk is an individual level thing, that means we've got to do this nasty thing of trying to understand people's risk perceptions and understand whether those risk perceptions are accurate, however we mean accurate, and whether we need information and such to somehow deal with those risk perceptions. Because that's what's going to drive a lot of the valuation, is their perception of risk or their perception of the change associated with this. So I've actually spent way too much time trying to understand some of the literature on eliciting risk perceptions, and it's taken me all the way back into the world of stated preference and all the things that you can do wrong in stated preference valuation questions. You can do that wrong in risk elicitation questions. But it's an interesting pathway to explore. It's what do people perceive in terms of risk? How is that affected by information? And is there some accurate way? Do people actually invest time and energy in answering your question when you're asking them about risk perceptions in a quantitative way? whole shopping list in terms of the chemical side of things. I think we've talked about pathways. I've not touched on this. We used a stated preference instrument. Lots of concern about whether these are valid or not in terms of eliciting the value of what you can do to improve validity, so we can certainly worry about that. We've mentioned this baseline risk issue, risk perceptions issue, heterogeneity, and then I think there's a whole host of other challenging things. Psychology of information provision. I don't know if anybody saw there's a recent paper in, I think, Journal of Economic Literature by Lowenstein on how people ignore information or accept information and the mechanism or psychology behind that. Of course, that will tie directly into what risk perceptions are and may help us explain some of those differences across different health endpoints. Endogeneity we've mentioned. I think this is a challenging one that I haven't really seen a lot of literature on. If I've got a heart disease risk associated with chemicals in the environment, and I've got a mortality risk, and I've got a cancer risk, and I've got a risk on recreational fishing, how do I add them up? And I know in the policy tools that we use, at least in the Canadian and US context, we have some sort of ad hoc mechanisms for how we add those up. I know in theory how I would do it if I had all those estimates, but I actually haven't seen good studies on how one would add up all those multiple cases. And so if anybody knows of some, I'd love to know about them. But I think in the policy world, those tools already get used. We already have, whether it's air quality or water quality tools to try to do these multiple risk endpoints. So there's some work to be done in there. And then the whole altruism case, I think, is just a fascinating one that I'm not sure how we deal with. The fact that we are willing to pay for more than just our own specific values associated with risk reductions. We want broader things and how we calculate those. And I love Happyville, so you can read Happyville as if you wish, and then we can chat for at least a couple of minutes. If you haven't seen Happyville, you can read Happyville. I start my graduate benefit cost course with this quote on the screen for the students to wrestle with.
So in relationship to this, so what's your take on CBA when people have wrong perceptions and beliefs?
Wrong perceptions and beliefs.
Well, let's say that we actually find that women actually
Yeah.
overestimate. So what's your take? Well, how shall we deal with that when we do constructive analysis? Or?
I mean, I think we have to try to figure out how to put it in the framework. I guess I kind of lean to the Bernheim-Wrangle approach. All right, how do we take these and sort of try to make them consistent? I don't think we should throw them out because they're perfectly informed. I don't know what basis we throw them out on. So I'd like to find a way to actually incorporate them in there. But it's tough. You're right. I talked for too long, I can tell. I've exhausted the audience.
Vic, on the chemical side, I mean, the big challenge is that we know so little about these risks, right? And particularly, I mean, there are new substances all the time, there are combinations of them, and how would we ever catch up in our perceptions?
Well, but you can be informed by them. We're learning about them. 20 years ago, we didn't know much about particulate matter. We talked about total suspended particles, and we had all kinds of other measures of how things affected health risks, and that's changed a lot, and now we have a much better sense of that. So we can't do it overnight, but I'd like to think that we have to just continue to chip away at the line of things all the way up to humans, and then try to provide information. I think that's why we've done well on the smoker side. But it seems smokers know what their risk is associated with heart disease and how it's higher than non-smokers. And it's probably through information provision from repeated study. But you're right, we have all kinds of new chemicals and interactions between chemicals. How do we get from there to communication and understanding? Don't know. You're not happy with that answer.
Yes. What I was hoping for was some kind of fire support to actually be more careful in the regulation. I mean, this is an ongoing battle for decades, of course, between the. So if we could use this as ammunition to actually have a more careful approach to allowing these chemical cocktails in our lives.
Yeah, fair enough.
Yeah.
Fair enough. So there may be some variance around the perceived risk. And for new things, that variance would be high, and somehow you take that into account when you do your initial cautionary assessment, saying, you know, it could be around this range, and so we need to worry about it. To be a bit careful, we don't want to get carried away on everything. But I could see that. I mean, that is one of the standard risk outcomes, is that new risks people worry more about than old risks or risks that they're comfortable with, right? Like ticks in certain places.
Yeah, but I think it's a fair point. The problem is really that the information that we have to determine baseline risk is an absolute disaster for most chemicals that we're handling. For a lot of the chemicals, we have absolutely no idea what the level of risk is, and that basically means we don't have the basis of the foundation to start working towards cost-benefit analysis or any type of assessment.
That's true, but that to me just, well, depending on the context, would say there's a reason to invest in research, because understanding those baseline risks is really important.
But it
Where
would be
do you start?
interesting to come up with an estimate on how much research or how much time
Yeah.
and effort
Yeah.
do we need
Yeah.
per chemical.
Yeah.
Because I mean, if we're just looking at the amount of chemicals that we have on the market right now that we're handling, that we're exposed to, we're talking about, depending on the estimate, between 30 and 50,000 chemicals. So that's the amount of chemicals.
Right.
We're not talking about interactions or any cocktail effects, but just 30,000 chemicals that we're all exposed to on a routine basis. Chemical industry is very innovative, so they're coming up with new chemicals, they're coming up with new uses,
Right.
which changes the exposure pattern.
Yep.
So it's a hell of a complex system,
Yeah.
and I think we have a lot of instruments that we can apply, that we can use for specific cases that are usually very information rich.
Right.
But what the hell do we do with those where we don't have? I don't have an answer there, but
Yeah.
I fully support that this is a major problem.
Yeah, no, I agree. I mean, it's a small piece of this puzzle, but if you believe the importance of baseline risks in understanding your stories, that would just say you really need to do work on trying to get those baseline risks right. I mean, they can change the answer dramatically depending on where you are on that scale. Right.
So go ahead. So you're holding preferences as something, this preference perception thing, I'm still grappling with that.
Yeah.
So if you take more of the behavioral psychology more seriously, then this holding preferences at a pedestal is something that's not influenced by our read of, in a sense, perception is what, is more subjective, and it's more what you know and have experienced, and then modified what you and
They probably
what was
interact.
it, primitive? Is that right?
Yeah, I don't know. I mean, I'm thinking about it, at least in this context, a little more simply. That we think about people experiencing X's from the outside world, and they're multiplying them by a beta, and that's their preference. But the beta is their preference. Those X's are also their perceptions of whatever the outside world is throwing at them. So we can never easily untangle those two.
Right. So in the empirical world, this is just.
It's exactly right. It's a challenge. Well, unless you know perceptions. Then at least you know that piece of the puzzle, and hopefully you can identify the preference part if you have a handle on perceptions, assuming that those two can be independently estimated. That's the structure, right? But if there's a relationship, if my perception of things influences my perception, then sure, you're going to get tangled up in those again. I don't think we really wrestled with that issue very much, right? We
Or should we?
Should we?
Assume that, I mean, is there any hope?
I think we should. I think there's hope for doing it if we can actually assess preferences, and then maybe we can start down the line of how to assess perceptions. Or if we can assess perceptions and start to understand how preferences may respond to changes in perception, but that's going to involve a different set of experiments. But otherwise, we've got this fundamental confound, and we're calling everything preferences. And then everything goes into marginal willingness to pay, and then we could be way wrong in what we're estimating. I mean, there's that old Mansky paper. It's the only paper in Econometrica that I've ever seen that I think only has one equation in it. So it's a very readable paper in Econometrica. But that does a beautiful job of just saying, these things are confounded, and here are the implications of not dealing with the confound and trying to work that way out. And that's, for me, that's been quite an instructive way to think about this.
I was thinking if you learn something about these things through age, because a lot of these risks must be objectively time dependent,
Yeah.
age dependent.
Yep, the dynamics are tough.
So you've got the, yeah, but I suppose you obviously had the age of people. So
Right.
how did you explore that avenue of?
We know that these vary by age, and so we have that as another one of those comparisons that we can do. And yeah, people do recognize that their risks get higher as they get older. What we don't do is that this is still a static analysis. We don't have something that says, through time, I'm going to change my behavior because I know this is my expected risk profile through time. That's a much more challenging problem. And that's another reviewer comment.
Well, yeah, old people should care less, I suppose.
Well, that's
a
not
number of
necessarily,
cases.
that's not necessarily true, though. And that goes back to that old story of that we used to value old people less in the mortality risk world,
Yeah.
right? I mean, in Canada, they were worth about 75% of young people. But if you're an old person, you don't like that outcome.
No.
And empirically, there doesn't seem to be much basis for that. Because it's, the actual willingness to pay measure of an old person could be higher than the willingness to pay measure for a young person, because again, it depends on if you're in that dead anyway world or in the declining world the other side.
One last question.
Okay, very basic question, just curiosity driven. The one thing is, how does the willingness to pay depend on the income of the people? Is there a connection, or how is
Absolutely.
that? And because you're expressing them in dollars,
Yes.
in absolute terms, can you? What happens if you express them in terms of percentage of disposable income, or percentage of income, or something like that?
Yeah, you can do that. I mean, you can take any one of these measures and just turn it into what percentage of their income. It's a pretty small percentage of income that people are willing to pay here. And typically, we would expect that their willingness to pay would go up with income because they have more money available for things, they can afford it. But the other, as I say, the unusual interpretation in this case is that wealthier people also perceive risks differently. And so the influence on willingness to pay shows up through a different pathway, because wealthier people can invest in other types of risk-reducing lifestyle choices or other things. They actually have a perceived risk that's different. And so their marginal willingness to pay is higher purely from that, as well as from the fact that they can afford more. It does run into a question that we don't touch, at least in this case, is that there will likely be distributional consequences of policies. If wealthier people have much higher willingness to pay, a policy is going to be more likely to deal with their preferences and outcomes than poor people. That's a separate analysis that is important to do, but we haven't done it in this context.
The second question was, how much does nationality play a role? So
That's a good question.
how different are things in, say, the Canadian context, the US context, European context, or something like that? So how does that compare?
It seems to matter, even when you're trying to hold other things constant, like income or purchasing power parity adjusted incomes and such. There seem to be some differences across countries. I haven't seen it for heart disease, but in the mortality risk literature, there are some differences. Don't know why. It could be because of socialized medicine structures. When you compare Canada and the US, that's the most common one. Very different healthcare institutions. Could be for other reasons.
So is the willingness to pay is higher in Canada than in the US? Is that the case?
I'm going to have to double check that one, but my sense was it's higher in the US. Mortality risk reduction value is higher in the US than in Canada, adjusted for these other factors that are different. There's a fairly new study by Laurie Chestnut and others that compares US and Canada mortality risk reduction values. But I don't know, has that been done in Sweden, comparison across the EU, or? There's a good thesis project.
Okay. Thank you very much, Vic, for a very
Pleasure.
interesting and rich presentation.
Thanks. Thank you.
And if you didn't follow it, all the details, you can see it again at the FRAM homepage in a week or so.
Yes, or if you